by Jeff, or if anybody had any questions following up on Jess's presentation about queer family building. I just wanted to open it up for that because I know a lot of us have conversations about this content when we go back to our workplaces, and sometimes things come up that we don't know. And so I just wanted to make space for that before I jumped into the rest of my presentation today. And I see we have some additional people coming on. But if I don't see any questions here in a minute, okay. So here is the beginning of the presentation. We're going to dive into today the advanced mental health considerations for 2SLGBTQIA parents and families. This is just a note I wanted to put in before we really dive in. I'm a member of Postpartum Support International, which focuses on mental health of pregnant and postpartum people. And when they would have their little section of their formal training for the certification in perinatal mental health on the queer community, there'd be a lot of, there's no research on this, we don't know, it's not documented. And so I just wanted to touch on the fact that queer folks have been having babies for a really long time. It's just that there wasn't money and research being put into tracking it. Transgender women and cisgender women both, who are not gestating, have shared hormone protocols between themselves and with lactation professionals who are used to working with the queer community, so that they can breastfeed children. Trans men and genderqueer non-binary folks have babies all the time. Lesbian parents have worked with, family and friends for sperm and have, birthed their own babies. And gay men have asked friends to carry babies for them. So let's keep in mind that this is not all new as of assisted reproductive technology. This has been happening for a while, and we've just now started studying it. I want to start first with language because I feel like that's where a lot of people stumble. And so just focusing on the fact that not everyone who gives birth wants to be called a mom. And so this is something that starts in the birth and maternity environment. So midwives, nurses, nurse practitioners of women's health, OBGYNs, genetic counselors even. We've got all kinds of people that work with pregnant folks. And we can't assume that anybody wants to be referred to any particular way. If you want to really do your best job, you can check in with everybody because you can't tell just from looking at someone whether or not they're a member of the queer community. And some alternative terms that I really like to promote are the birthing person or gestational parent for whoever is pregnant, and then non-gestational parent or birth partner as an alternative to just father, because not everyone who contributes sperm to growing a baby considers themselves a man or father. And then an alternative to breastfeeding is chest feeding, and then a little bit less commonly used is infant body feeding. I want to talk a little bit more about language inclusion and why it matters to these communities. There was a really interesting study in 2021 that has not been replicated to my knowledge, but it looked at publications about pregnancy and postpartum, and it really all addressed cisgender women and did not include anything about gender diverse folks. And so when 98.8% of the publications aren't inclusive, we have a lot of people who continue to feel invisible and erased. And then we have healthcare providers and mental health providers and all kinds of other folks that support families who just aren't really used to thinking of parents as being anything other than a man and a woman, and cisgender at that. There was a really interesting study in 2022 that reviewed that increasing language inclusivity helped to reduce discrimination experienced by trans and non-binary parents. So for the people who say that, these terms don't matter, it doesn't make a difference, there is research to the contrary. There's been a lot of attitudes that have come up when surveying healthcare providers about we just treat everybody the same. And that's why it doesn't matter that we ask. But we found that it's actually to the contrary. When we find that we don't ask, we can't accommodate the unique health challenges that come with, some of the people in this community. And so failing to screen for sexual orientation and gender identity minorities means that you really have failed to provide the standard of care if you're not asking. There's this one really interesting video. If you're someone who does a lot of training for staff in a healthcare or mental health environment, this might be worth checking out. The title is "To Treat Me, You Have to Know Who I Am." And so it really goes to talking about rapport with working with anybody, especially parents, to make sure that you are connecting with them as a human being and making them feel seen and understood in order for them to disclose to you like important information that affects their care or affects the care of their baby or their children. Starting here with the journey to parenting for queer folks. Almost a third of people surveyed in 2019 as queer were raising children. This includes biological children, adopted children, or foster children. Same-sex, same-gender couples, when compared to heterosexual couples, are 6 times more likely to be raising foster children and 4 times more likely to be raising an adopted child. And that can be adopted children from their partner that had with a prior relationship or a child that they adopted through other circumstances. Often having children for queer folks involves assisted reproductive technologies, queer network of peers, or adoption or foster care. I'm not going to go into this very much because Jess went into it last week talking about queer family building. But I will say that the desire to create a family for a queer couple can be medically complex, expensive, and require extensive and difficult decision making. And these are all stressors that can impact mental health. I want to touch on some global perinatal data just because we don't necessarily have this granular information for American folks, but we do have it, especially in the Dutch and British and Australian populations, a little bit more information. And so we're going to go over that, but keep in mind that it might not necessarily be generalizable, partially because of culture and partially because of universal health care in these nations rather than the more scattered sort of third-party payer system that we have here in the United States. So among Dutch trans men, after they had medically transitioned, about 3/4 of them had a cis female partner who was inseminated with donor sperm. So we have a high rate of outsourcing sperm for 2 people who have the same reproductive organs in that community. But in the UK, there was a survey of lesbians and non-binary people, and 21%, or 1 out of 5, had 1 or more children, and about 3/4 of those were biological children that were conceived without medical intervention, while about 11% used IVF and 8% used IUI. And then even smaller amounts used adoption, fostering, and surrogacy, which is probably one of the most expensive options. Right now, and even to what I've checked today, Australia is the only country that routinely collects data on gender and perinatal services. So like midwives, OBGYNs, whoever is helping catch the baby or deliver the baby, surgically, is putting on like a birth certificate what the gender is of the parents. We do not collect that data here, so it's very difficult for us to track trends in those things or to do more retrospective research. Lesbian mothers, interestingly enough, may be more likely than their heterosexual peers to lack social support, particularly from families of origin, and may be exposed to additional stress due to homophobic discrimination. Trans parents, whether they be gestating or not, often experience higher levels of loneliness during pregnancy. And the bisexual women, which is the largest portion of the LGBTQ parent community, in the postpartum period have the highest risk of PMADS if living in non-urban areas, are partnered with a man, and if they are not connected to the queer community. So a lot of times we're not going to recommend to people, you should move to a city, or you should be in a relationship with a woman. That would not be a thing that we can really manipulate. But we can help people connect to the queer community, especially to queer parenting resources. Because if a queer person is connected to a lot of queer people, but not a lot of queer parents, they're still going to be kind of isolated in their experience. One of the biggest pillars of perinatal mental health is community. And so we have to think about their community, not just as other parents, but as other queer folks and queer folks who are parents. Gay fathers reported less positive feelings at the end of a pregnancy when compared to lesbian mothers, and more positive feelings about parenthood in the early postpartum weeks when compared to heterosexual parents. We have one study in Israel that talks about gay fathers using surrogates, and more of those fathers experience PMADS compared to 8.8% of fathers in the general population there. So we see that going through assisted reproductive technology and using a surrogate is probably more stressful than conception without medical intervention, because not only is there a big financial investment, but there's also a lot of uncertainty because that baby is growing in a third person's body who they may not know or be connected to as well. And so there's a feeling of helplessness that a lot of those fathers talk about. Non-gestational but expecting parents report being perceived and treated as though they are not the real parent by other people in their communities. Just because they don't look pregnant doesn't mean they're not affected by a pregnancy, and we have to keep that in mind. For the other mother or lesbian non-gestational parents, feelings about biology and connectedness can be dependent upon their own desire or not wanting to biologically conceive, or the unique experience they have had of being infertile or unable to biologically conceive while being partnered to a pregnant woman. So sort of watching their partner, if they were not able to conceive, go through a pregnancy, there can be envy and complex feelings, even though they are having a baby and growing their family. So we just have to acknowledge what the context is of people developing and growing their families. The other mother who is not gestationally carrying can have a wide range of feelings. We touched on this. Concerned about not gestating and potentially having a different relationship with their child because there's not that biological bond. The social support component that we talked about, that community component, it significantly correlates with perinatal mental health and wellness outcomes. So the non-gestational or non-pregnant parents in one study talked about a lack of resources for them, including a lack of postpartum mental health services, a lack of things that address intersecting identity, like being a parent and being queer, or being a parent and being queer and being a part of a marginalized community racially or otherwise. And there's a real lack of research addressing the health implications of pregnancy for non-birth parents. There was this one really interesting study that came out last year that had a little bit of a contrasting view on lesbian mothers, and it was also a Dutch study. They tended to feel, both the birthing and non-birthing mothers, more competent and less overwhelmed than their heterosexual parent counterparts. So the theory is that these mothers, because they had very intentionally gone into parenthood, there was no accidental pregnancy, they had all used, assisted reproductive technology to become pregnant, They were more prepared. They felt less overwhelmed. But they also found that the mothers who didn't carry biologically felt a lot more pressure than heterosexual men reported to prove that they were good parents. Like they could be a good mother without carrying biologically. Um, Lesbian mothers overall tended to experience more positivity during pregnancy and higher levels of confidence in their parenting than other couples who used assisted reproductive technology. And that looked at gay father couples and heterosexual couples that also used assisted reproductive technology. So I think that what we have to look at here is probably some of the cultural narrative around women being innately predisposed to parenting simply by being women, and some of that sort of bolstering the confidence of mothers and how it sort of undermines men and fathers because they're not told or displayed in the media that they are inherently good fathers, and that's just innate in them. So really a lot of this is just challenging maybe some gender stereotypes that are perpetuated culturally and in the media. I want to talk a little bit about some terms that are sometimes used incorrectly, both in the greater media, by your patients, and sometimes even by healthcare and mental health providers. I want to distinguish between gender dysphoria and body dysmorphia in non-binary and trans parents. I've heard anything from gender dysmorphia to body dysphoria, which is sort of like some snow cloning of those terms. Gender dysphoria is really an incongruence and discomfort because of gender and sex assigned at birth not lining up. And so it's a term that really is distress, dysphoria, the opposite of euphoria. And this is distinctly improved with gender affirming clothing and healthcare. Does not have to be medical intervention, but this is not a mental health disorder. This is just the experience of being transgender and having the body and the sense of gender not match. PMADs can be a lot more prevalent in transgestational parents. So that would be trans men, non-binary people, agender folks, like anybody who just does not identify as a woman, but who is capable of pregnancy, with an exacerbation of body image issues and the dysphoria common with weight gain and the breast enlargement in particular. Because if someone identifies as a man and they've been able to wear a binder for years, but now with pregnancy, their chest is growing because of those mammary glands, and they can't wear a binder like before, that can be really distressing because now they might not be perceived as a man like they were before. And it's really individual how people manage that in pregnancy. There was this one really interesting study from 2019 that talked about how trans folks who were pregnant experienced pregnancy. Sometimes people would, you can call it socially detransition, where they tell people that they are a woman, even though they're not identifying as a woman, just to avoid the discomfort of being a visibly pregnant transgender man. Or they can pretend to be an obese man. And I can say that in my practice, I've definitely worked with folks who've attempted this. People will sometimes wear, very masculine clothing, like button-down shirts and dress slacks and a bow tie with suspenders, and sort of compensate to keep like the rounder belly from looking like a pregnant person. And so people have sort of those three options when coping with being in public and pregnant and sort of navigating gender. But what we want to really distinguish this gender dysphoria from is body dysmorphia. And this is a lot less common. It is a mental health disorder based in really extreme anxiety, preoccupied with one particular perceived body flaw. And this is not improved with medical care. It's not improved with plastic surgery. really the only way to manage this is with mental health care, such as anti-anxiety medications and therapy, because the perception of the body part being problematic doesn't really change even when it is altered. I want to have a bit here about intersex parents. If you attended the LGBTQ 101 talk, intersex is where someone has biological traits of both of either genetics or hormones or other things that is a combination of male and female. So they might have XY chromosomes, but have ovaries. And so it's a combination of reproductive or sexual anatomy with that does not match. Sorry, I'm stumbling. It's like the sex spectrum is like a color spectrum, and people can have a variety of combinations of hormones, sexual traits, and genetics. And so a lot of these people don't necessarily know that they're intersex until they go to have babies. Sometimes they're sterile, sometimes they just have more pregnancy complications. They did a 2020 study of trans, non-binary, and gender expansive intersex people, and about 12% of them had been pregnant. Of the ones who had been pregnant, over half had one prior pregnancy, a quarter had two prior pregnancies, and the last quarter had about 3 or more prior pregnancies. But of those cumulative pregnancies, only about 40% resulted in a live birth. Intersex folks have a lot higher risk of pregnancy loss, with 33% of pregnancies resulting in miscarriage. And so higher rates of stillbirth, higher rates of unintended pregnancy, and other complications in the perinatal period were also present. So this can be something that people might discover when they are under your care. Because if someone is intersex, their uterus may not have fully developed. And so it might not be able to accommodate a full-term pregnancy as well. Or someone might discover that they're infertile because their ovaries did not develop the way they were supposed to. So just keep in mind that this is something that is more common than we talk about often in the medical community. I wanted to talk about PMAD risk factors for the queer community. And so there's a lot of overlap here. We have minority stress, which is rooted in discrimination, which affects social determinants of health. We have increased risk of trauma, and we have the PMAD risk factors that we sort of covered earlier in this presentation about journey to parenting, how other people perceive parents, their concerns about their parenting quality because they may not be the gestating parent, and things like that. They all contribute to anxiety, depression, and stress overall. There's a lot of current legislation regarding queer healthcare, especially in regards to transgender folks, that can cause more anxiety and also a lack of medical and mental health care. We talk a lot about violence against trans people in the news. We see cases of teenagers who are being killed, like in Utah pretty recently. Concerns about protection for gay marriage. All those things are felt very deeply by members of the queer community, and also concern about future violence. So the lengthy and stigmatized legal process that can happen for same-sex marriages or parental adoption, things like that. We don't have a way here in the United States where a lesbian couple, for example, who are married, when they have a baby, it's automatically considered a child of both women, like they do in some other countries now, which makes there are more legal barriers to both mothers being recognized as caretakers and responsible for that child. There's also a lot of steps that can go into reproductive assisted technology, a lot of screening, a lot of psych evaluations, things that cisgender heterosexual couples don't have to go through. Um, and there's a lot of financial burden with assisted reproductive technology and the legal things that have to go into those plans and the adoption that we talked about. And there's also the additional PMAD risks that go for anybody using assisted reproductive technology, which is where there are higher rates of NICU stays, perinatal loss, and then compounded grief, because so much went into conceiving this child. And so any threat to that baby's well-being is especially impactful. There's not a lot of research specifically about traumatic birth in the queer community, but we know that lots of queer people outside of the perinatal period have a lot of trauma at the hands of medical providers and sometimes avoid care because of discrimination. So there isn't much specifically on traumatic birth in trans and non-binary parents in particular, but predisposing factors include a history of mental illness, trauma, abuse, lack of social support, and poor care or obstetric violence. And a lot of these are experienced by members of the queer community in general with mental illness, trauma, abuse, and lack of social support. Nearly half of trans adults surveyed in the US in 2023 say their healthcare providers know not much or nothing about how to provide care for trans people. I think there's a baseline level of understandably scrupulous folks when it comes to the medical care they receive, but to think that nearly half of a population doesn't think that people really know how to take care of them, that's a red flag for us in the medical community that we need to do better. We need to learn more and we need to do better. Learning more about trans folks in general, I think, is going to prepare us to better take care of them in the birth community, in the birth environment, I mean. Again, the note like early in the presentation, be brave and ask people how they like to refer to things like parts of their body or chest feeding or breastfeeding, so that you're not using a term that is really causing some discomfort in the patient, no matter what you're used to using. Pregnancy and lactation involve two body aspects, or they are two aspects that are socially and culturally associated with women. However, there are a few biological differences. There are only a few biological differences between male and female breast tissue. Lactation and pregnancy are viable processes that do not depend on sex. Even for the latter, it is only necessary to have an organ capable of gestation, ways to favor mammogenesis or growth of the breasts, and lactogenesis, which is encouraging the breast to produce milk in trans women, have been established, especially through estrogen. There are protocols to promote lactation in trans women, usually used for adoptive mothers or those whose children have been born through traditional surrogacy. But I will say that there is not a lot of research. There's only a couple of case studies about tracking the growth and development of infants who are breastfed by their trans mothers. And so this is something that I feel like the pediatric community and the queer community need to come together and sort of research more so that there can be more of this that is supported, making it more accessible as long as we have reassuring data that it's adequate nutrition for infants. There's a trans woman who had breastfed her baby, and there's a little quote from her. I always thought breastfeeding was an important connection to have with a child. Because I couldn't carry the child, I thought it was going to be the next best thing. I'd seen many people have that connection through nursing. That felt like something I needed to do. I knew it was possible for trans women to breastfeed, but I didn't know much about how to do it. Some intentional topics of discussion for non-binary and trans folks who are in a pregnancy-related environment, like getting OB care or in preconception counseling, should address if their gender dysphoria is affected by body feeding, If they have had or if they're planning to have top surgery or what is also known as a bilateral mastectomy, what sort of lactation care they'll feel comfortable accessing as a transmasculine person, and deciding if or when to restart testosterone, because testosterone is clearly contraindicated in pregnancy. I want to talk about the perinatal resources out there for queer parents. Um, there's a lot. I could not include all of them here, but these are some of the ones that I really recommend. Baby making for everybody, family building and fertility for queer and solo parents, queer conception. The Natural Mother of the Child is a memoir of non-binary parenthood that I really, really love. It is not an LGBTQ 101 book, but it is a very interesting set of essays to form a memoir of a non-binary person who uses he, him pronouns, who carries the second child in his family after his wife carries the first. And it flashes back throughout his life to when he was being raised as a little girl and how he never really felt like a little girl, and how like interactions with his family went as he got older and identified as non-binary, found his wife, and as he was a pregnant but masculine presenting adult in the United States, and all the things that they went through, like legally and socially. It's a very, very interesting and eye-opening book. The lactation protocols for inducing lactation, either in non-gestational mothers or non-gestational trans mothers, are here. There is a breastfeeding commonly asked questions for trans and non-binary parents as well. And then in 2020, the Academy of Breastfeeding Medicine developed a clinical protocol on lactation care for the queer community. And so that's really important for any lactation consultants or anyone working with brand new parents who are trying to chest feed. Perinatal mental health resources as far as groups. There is a queer pregnancy and infant loss group that is virtual at rtzhope.org. There is a queer trying to conceive virtual support group that is non-denominational through the Jewish Fertility Foundation. There's Rainbow Families, which has, queer parents, groups like Single Parent by Choice, which is from conception and forward, and then non-gestational partners groups and more at rainbowfamilies.org. There are some trans-specific perinatal resources at transfertility.co and transmasculine reproduction through UCSC. And then there's a Facebook group that talks about trans reproductive support, and parenting queer .co.uk in Britain, another good English resource. A friend of mine and another colleague developed this like series of pictures to show like queer families. We have multiple moms here. We have some trans men who are pregnant, and just showing the various ways that families can look. And then I wanted to point out an upcoming free webinar given by the Fenway Institute. They are the National LGBTQIA Health Education Center, and they're giving an upcoming talk about care for queer families. And this is talking more about the children in families with queer parents, so older children than really the VNPC focuses on. But I think a lot of us work with families as they continue over time. And so some of this will be relevant to our care. So I thought it would be a great free resource. That is coming up in a few weeks on April 10th at noon on a Wednesday. So just know that that is something you can look into if you're interested. There's also a queer and trans parent support group, which is also free through Postpartum Support International, which is really the largest mental health organization for parents in the United States. They run the maternal mental health hotline, which is not just for people who identify as mothers, but unfortunately they couldn't get more inclusive language when they got the government contract. So know that they also have free online support groups every week, hosted by members of the queer community. And I believe that is what I have for you. Does anybody have any questions?
Thank you, Featherstone. That was very informative. And we appreciate you being here.
Absolutely.
I'm not seeing any questions right now. If anyone has any, please feel free to put them in the Q&A, or you could probably just put them in the chat as well, since this is a bit of a smaller group.
But if not, I know that's a lot to digest about the wide variety of experiences that queer parents can have. And there's a lot of data in there, but it's highly individual, and queer people aren't a monolith. So asking questions is the most important thing that any of us can do when working with queer families.
And oh, there's one question. Can you talk more about trans feminine lactation? Is this something that they need or can use accommodations for in the workplace?
That is an interesting question. I don't know how the law recognizes breastfeeding for non-gestational parents, even without the trans feminine component. I think it would probably be highly dependent on the employer about if they can use accommodations for that. When you say that it's something they need, Spencer, can you be a little bit more specific?
I just don't know that much about trans feminine lactation. Like, I don't know if it's something that, for pumping for people who are the gestational parents, they need breaks because they're producing a certain amount of breast milk. So I don't know what the process for trans feminine lactation is. If it produces a certain amount of breast milk that would necessitate leave in the workplace, or if it's a small amount that really I don't even know how, I guess if you can talk about how trans feminine people lactate, and then whether that is like a specific time sensitive process that they would need or could use accommodations for based on how much they produce.
I think that a trans woman who is lactating is definitely going to need breaks and consistency, because lactogenesis, like the production of milk, and sort of stimulating that endocrine pathway in the brain, is going to need a lot of consistency. And a lot of times people start to induce lactation before a baby is born because they need their production to be higher by the time the baby comes, because they're not getting that sort of innate hormonal change because they're not carrying the baby. So I think that the need to pump every 2 or 3 hours, a lot like someone who had just delivered, would be really important. I will couch this as like, I am not a lactation consultant. This is something that connecting with a lactation consultant who's really competent with the queer community and inducing lactation would be the best person to work with. But I definitely think that it wouldn't be someone who could induce lactation and maintain a supply without regular breaks. And those breaks might start before the baby is born. And so having an understanding and flexible employer is probably going to be something really important for those folks. And if they're not in that environment, championing for that through HR or other, pathways in the company, or finding more supportive employment would probably be really important for those folks.
And you may be lifting up a interesting policy implication there, Spencer.
Yeah. Because trans women don't have legal documentation to the fact that they're women necessarily. There's a lot of vulnerability in having your legal gender changed and having people like challenge that when your ID is provided. And so some people choose where or when they want to disclose their identity. And if their driver's license says male, but they're a woman and they're trying to induce lactation, and maybe they dress androgynously, so it's not very clear. It's going to be really hard to have that conversation with an employer. Like that's a very outing conversation.
Yes. I would
And so
imagine, especially if you aren't aware of what the law says already. So what's already there to support you or not. Because it's making me wonder, and I really can't remember, like the break time for mothers policy and the Pump Act. I'm trying to remember the exact language in those policies, whether it says lactating people or just lactating mothers. I can't remember.
and do they consider a mother if they're not gestating?
Right. So
Yeah,
food for thought, definitely.
absolutely. Thank you so much for that question, Spencer.
Any other questions? Oh, Spencer says, as we look into this, we can circle back if we uncover answers on that language. I would love that. Thank you so much, Spencer.
I would love that too. I know a lactation consultant in Portland who named Brenna. I met her at the perinatal mental health conference last year. She works almost exclusively with the queer and trans communities. And I might loop back to her because I feel like she's got to have dealt with this before, about how people are experiencing this in the workplace. Maybe not so much from a policy perspective.
Absolutely. Any other questions before we wrap things up today? Okay, well, as Lauren put in the chat, we do record our webinars, and so it will be posted on our YouTube page. If you want to dive back into all of the information that Featherstone shared with us today, you'll be able to look at the recording later. We appreciate you. We are glad that you came to this webinar today, and please look out for the next part in this series. It'll be next month on this is the third Thursday. Sorry. Yes, it'll be on the third Thursday again next month. And so look out for that and our regular monthly webinars, which are on the fourth Tuesday. Oh my goodness.
Third
my
Tuesday.
mind today.
You got it. Third Tuesday.
Third Tuesday. Thank you, Lauren. Thank you all. Have a good day.